So all day I've been introducing people who need no introduction, and that's why my introductions have been short. Tom Insel is a neuroscientist and psychiatrist and the co-founder of MindStrong. He led Verily's mental health initiative from 2015 through 2017, and prior to Verily, Dr. Insel was the director of the National Institute of Mental Health at the NIH from 2002 to 2015. Welcome, Tom.
Oh, thank you, Lisa. And this has been just a terrific day. In fact, since I'm almost the caboose in this train, maybe we should take a moment and thank Lisa for putting all of this together. So congratulations. Just been an extraordinary set of talks. And as I've listened through the day, I kind of relived a lot of the excitement I felt in the years when I was at NIMH about developing new technology, either for genomics, like we heard about from George Church, or for getting the biology of the brain and at various levels. When I left NIMH, I often tell the story that I was giving a lecture in a room sort of like this, but mostly with family members of people with serious mental illness, and someone got up at the back of the room and they said, "Dr. Insel, you don't get it. I've just been talking about all this great science we're doing." And they said, "You know, our house is on fire, and you're talking about the chemistry of the paint." And I really took that to heart, because it occurred to me that what we needed was some science and technology products and interventions, including biomarkers, that really could make a real difference in real time for real people. And I had spent an awful lot of taxpayer money, about $20 billion by that point, developing stuff that made for great papers, but maybe not great products. And so in leaving the government and getting into the private sector, I began thinking about issues, particularly in Silicon Valley. You think about issues of scale, and how do you have an impact that really scales in the way that Mary Lou was talking about. I also began to realize that while we have a huge need for better tools for genomics and for neuroscience, and that is the revolution that we're in right now, and what a great opportunity, what an amazing time this has been, that actually where we've really been neglectful in a way is understanding how to measure behavior. So no one's talked about this today, so I'm going to spend the next few minutes talking about behavior and what we can do in this tool that's now called digital phenotyping. So the way we do this today is patient comes in to see a clinician, and the clinician's assessment is, how are you doing? That is the assessment tool. That is the technology we have. And it's okay. It gives us information. It's all subjective, which is important and of value, but it's totally episodic. So what somebody reports is a good reflection of how they've been in the last few hours. It's entirely based on what the provider's needing for some reimbursement process usually, and it's always reactive, meaning it's way, way too late if you want to be able to think about prevention or preemption. What we need is a system that's objective, continuous, ubiquitous, and proactive. Now, how do we get there? What would it take to get there? What does that technology look like? And amazingly, it's not that complicated in a weird way. But I should say before I point that out, that the need, or the fact that we don't do this well, has resulted in the kinds of data that you heard from Mary Lou and earlier this morning from Roz Picard about the huge disability from depression, from psychotic illnesses, from a range of mental illnesses. And the problem is that without objective measurement, we're not able to get early in the course of illness. So everybody is seen at stage 4, almost by definition. They come through a crisis, which is not when you want to be able to diagnose and intervene. And we do a really lousy job of diagnostics without any sort of biomarkers to develop the diagnostic criteria. So what we're looking to do with new technology is to change the way we do clinical trials, to change the way we do clinical care, and ultimately to affect population health. And my argument with you is that's very, very simple, that all of that requires doing a better job of measuring cognition, mood, and behavior. And as it says here, we can't manage what we can't measure. And the fact that we don't measure in any objective way is one of the reasons why we haven't managed this set of problems better over the last 4 decades. So here's the technology. Every one of you has it in your pocket. It's an extraordinarily powerful computer. In fact, as it says here, more powerful than the computational power we used to send those guys to the moon. And what is amazing is it's also incredibly ubiquitous, right? So it's not just people at MIT or sitting in this room. We have 3 billion smartphones in use, going to 6 billion within 3 years. And because we are not talking about a first world illness, this is a technology that does scale. It allows us to address the global mental health burden, which is much, much greater than the burden that we know about in the United States. And I find particularly optimistic the fact that the market share that's growing most of all for smartphone use is in the Asia-Pacific region, which is an area that really does need a new kind of an approach to behavioral health. I don't frequently quote Chief Justice Roberts, but I couldn't resist because I think this is such a cool comment that a visitor from Mars might conclude that smartphones were an important part of human anatomy. And I think all of us can relate to that. So how does this work? What is this digital phenotyping idea? It's actually very simple. You take raw features. You can grab the sensors, which are on every Android or iOS phone, activity, GPS for location. You can measure sociality by just saying email out versus email in, text out versus text in. There's nothing complicated about that. You can grab speech and voice the way Sandy Pentland and all of his offspring at the MIT Media Lab have been doing for about 2 decades. And there's wonderful information to be taken from measurements of everything from speech itself to our voice itself to the coherence in speech. What we focused on mostly is what we call human-computer interaction or the keyboarding, the way in which people scroll, the way in which they type. My colleague Paul Dagum, who started this project, actually started it when he was in a cybersecurity company. His job was he was a CTO for a big cybersecurity company in Silicon Valley, tracking hackers. And what he discovered was that he was able to identify digital fingerprints from the way people typed. The latency between delete character, the way they scroll, the way they do find various things on the keyboard. So taking that information and through the beauty of AI, he identified a set of digital biomarkers. He did a series of then clinical trials to try to figure out whether you could use this not just for finding hackers, but maybe for even understanding something about cognitive performance. So ultimately, this grew into, through 3 large clinical studies, exactly what we had been hoping for, which is a fully passive, objective, continuous, ubiquitous way to look at mood and cognition. And I'll take you through a little bit of the data for that so you get some idea. So concept is you're pulling off features, there are about 45 different features from the phone that have to do with this human-computer interaction. Each one of them has some 24, 25 different temporal transforms that we can use to create a total of about 1,000 biomarkers, potentially. And then to do studies in large numbers of people where you ask, which of those 1,000 potential biomarkers actually seem to be relevant to important cognitive behavioral mood variables, and then by this process of replication and doing leaving one out kinds of scenarios, we can get some idea of which things actually might survive to be useful biomarkers. Here's what the data look like at a first cut. So in this case, this is the very first study ever done with 40 subjects. They were given about 3 to 4 hours of gold standard neurocognitive assessments. And that's all of the things that you see there on the left, this delayed free recall, the verbal learning test, logical memory, all of this stuff. Very traditional, actually rather boring, very labor intensive, done in a laboratory one time. These are the constructs that those map onto, and these are 275 of the 1,000 potential biomarkers that one could measure. They don't all seem to track with these kinds of test results, but some of them do, and they do in interesting ways that cluster. And in fact, if you take some of these 275 features of your keyboarding behavior, and you begin to look at them more closely, you can find that they cluster in a way that if you take the 9 or 10 best, you can get very, very high correlations with the gold standard, whatever you want to call that, neurocognitive assessment. So over here, you have the actual tests that were done, digit forward, digit backward, trails A, trails B. For those of you who are in the world of neuropsychology, this is 1970s neuropsychology, and it's what's used in every clinical assessment that's done today for cognitive assessments or cognitive performance. These are the scores, but here's the real key to this. So if you take the top scoring, 10 top scoring digital phenotyping features, these are the kinds of correlations you get with the actual performance on the cognitive assessment battery. The point being that these are about as good as the test-retest scores for those same assessments, meaning that here we have a tool that's entirely passive, ubiquitous, actually, in this case, longitudinal, real world, ecological. It gives us pretty much a surrogate for what we've been doing in laboratories with a 3 to 4 hour time frame, which will never scale in the way we want. And this, of course, could be global. Amazingly, in a study that we then did with Stanford, we took another 100 subjects, did the same thing, but in this case, they had Fmri as part of a depression intervention trial. And so we took the features here. These are just two of the many digital phenotyping features we could use. One that was associated with cognitive control and one that was associated with reward on the neurocognitive battery. And sure enough, they associate even somewhat better in terms of the measures with the connectomic measures, the Fmri measures that we were interested in using a bold signal in the same subjects for whom they both had the phone, they had a neurocognition assessment, and now had Fmri. So these fit together pretty well in a way that at least suggests that this isn't just chance, that there seems to be some sort of biological validity to this. And then the real question for us was, okay, we've got the association with neurocognition, the association with the Fmri stuff. Will it be useful in a clinical study of mood? So this is looking at just one potential mood marker. It's a screening test called the PHQ-9, again, a sort of gold standard that's used. And you can see that, again, we can find features that aren't perfect. The blue squares or green squares are single features. The blue triangles are what happened when we combine multiple features. So now these are signatures as opposed to single biomarkers. But again, we're up in close to that 0.8 area, which is about where we want to be in terms of a correlation to suggest that, hey, we have the ability now to begin to replace the standard measures, in this case, measure of mood, with something that every one of you has sitting in your pocket. So my argument is that we've got something that at least looks like, and I'd say these are early days. We like to say this is the first act of a 5-act play. So we've got the feasibility demonstrated. We still have a lot more to do with large clinical trials outside of a typical research environment. But at least where we are now is we know we've got something that does fulfill many of these requirements in the sense that it's objective, continuous, ubiquitous, and allows us to be proactive because we can get data continuously before someone shows up in an emergency room or before they're re-hospitalized. But most of all, what makes it amazing is it's completely passive. So we're never asking someone to do anything except to use their phone. And as I showed you in an earlier slide, we're using our phones, we're touching our phones about 2,600 times a day on average. Actually, in this room, it's probably well over 5,000. But every one of those touches is for us a data point that we learned from. And that is really, I think, the excitement of this approach. It's funny because lately I've been reading so much about how smartphones are the basis for everything that's gone wrong in our society. There's a wonderful piece in The Atlantic this month. The title is How Smartphones Destroyed a Generation, about the danger of smartphones, especially for young people, because they're no longer social, they no longer have any ability to actually interact with each other face to face, all of which may be true. But the thought here is that this same technology may have a plus side that we haven't yet fully mined. We're now thinking about how can we use this in addition to refine diagnostics, so we can combine this with cognitive testing, with neural evaluations like fMRI, and to get this very deep behavioral information so we can subtype depression, PTSD, schizophrenia, and many other illnesses to get a much more refined sense of how this works. Now, for us, as we've taken this forward to various clinical environments, almost continually I get the same response from payers and providers, which is, oh, this is really great, but you must realize the last thing that we want as physicians, as providers, is more data. We can't handle the data we have now, and we can't handle the patient load we have now. We're not interested in more, we're interested in less. So if you're just giving us something that's going to take 1 nanosecond of additional time for us in the clinic, it's a non-starter. So we've begun to think about, all right, how do we refine this so it really can be used for decision support? It becomes a green light, yellow light, red light for someone in an emergency room, for someone in a clinic. What we're trying to do is to get the signals that predict relapse, the signals that predict recovery, those signals that might tell us which troubled 17-year-old is on the way to psychosis, which 23-year-old Nathan just talked about who stopped their medication on an antidepressant, which one's going to relapse and which will not. And those are the kinds of things we're looking at. That's a small part of this space, the assessment side. And what we are increasingly impressed by is the need to use digital tools for what we call the efferent limb, not the afferent limb, but for the limb that actually deals with the interventions. And by that, I mean building in the tools that can be every part of this kind of mental health care environment that can be done online. And in this sense, you could argue that if there's one area in medicine that's going to be transformed by digital technology, this is it. Because we don't need surgery, we don't always need pills, and we don't need necessarily any true device if you can provide a whole range of evidence-based, useful psychosocial interventions face-to-face. You can do them usually online. And most importantly, if you can do it well with big data and with AI, you can even do it better potentially than you're doing it face-to-face. This is the kind of 3 buckets I often think about in this space for what those interventions look like. Some of them are very much focused on consumer needs. The classic ones are built around peer support. Think about Alcoholics Anonymous online, how you could scale that, how it could be in multiple languages, how you could build community. There are companies doing that now, incredibly interesting. They're growing at a viral pace. One company just this week surpassed 1.3 million monthly users. They're actually serving more people than the brick and mortar mental health system. Pretty cool. Another area has to do with what providers are asking for, and there the secret sauce today is collaborative care. How do you take a very fragmented system and knit it together in such a way that primary care, specialty care, nurses and care managers all are working from the same playbook in a way that's integrated. And finally, there's all kinds of opportunities working with large insurance companies or large provider systems where you can do a huge amount to improve both the way care is recorded, like the electronic health record, but even more importantly, developing ways of creating quality metrics. That's really important for the healthcare system. Those are the things people are asking for, is how do we measure quality? That's how ultimately reimbursement will be made. We don't do that very well. This is, again, giving us an opportunity to be able to capture that. I just have a sort of final thought about all this, and that is maybe in a way to help you think about this, because I think this is happening quickly and it's going to be extraordinary. There's sort of 3 things you need to think about. We've been talking here about the assessment piece, which I call this digital phenotyping, the sensors, the human-computer interaction, voice, and other measures. I just mentioned to you about the mobile interventions and what's possible with peer support and coaching and psychotherapy. You can do crisis intervention in a way that's never been possible before. You know, young people are not going to call somebody on a hotline. Nobody uses their phone, their smartphone, to talk on. It's funny, Mark was talking about this before. It's like we're shocked that people actually think about this as something to speak with, because you only do that now with AR, with Siri or with Google Voice. You don't actually, especially young people, don't use this as a phone, but they will use text. And so Crisis Text Line has developed recently to provide immediate, on-demand care, which is exactly what's been missing in this space. And then this whole ability to capture metrics and to do the coordination, really important. But most important is pulling all this together to create a learning mental health care system, something we've absolutely missed, and now we absolutely can do with this sort of technology. And remember, this isn't building anything that we don't already know how to do, except we have to collect the data and learn from the data and continue to build that infrastructure. This is the data science problem. It's not a hardware problem at this point. My last point is that I've told you about sort of half of where I think the challenge is going to be, and that half is in demonstrating the value of this approach, and the other half is going to be doing this with public trust. We haven't talked about this much today, but we think all this stuff is very cool. A lot of people think all this is very creepy. And we're at a point now where it's going to be essential for us to bring the public on, with us, or they are not going to let this happen. It's really, really important that we think through both the unintended consequences of what we're building, and we think through the spirit in which it's being built. So when I talk about value, what I really mean is that's efficacy, showing that this thing works, that it works in the real world, not in a research project, but in the world of clinical care, that you can get ongoing engagement, and that it, as I mentioned before, doesn't create more work. You actually get efficiency. What I mean by trust is actually quite different. That is about doing this with a way that's transparent so that people understand what you're doing, that the users have agency, and users in this case means patients and families, that this is about giving them something that helps them and solves their problem. And responsibility, enormously important. So this has to do with privacy and how all of us take on the accountability, responsibility, and really the integrity of protecting this space. The way I sort of short circuit all this to say we are building tools to empower patients and families with information, high quality information that makes a difference for them. And I think if you use that as your goal, then the value and the trust are going to follow pretty well. But I can't emphasize this enough, because I think it's really going to be essential for us to be thinking about protecting public trust here and ensuring it, or it's going to come back to make sure that we will never be able to develop some of the things that we all dream about. Thank you very much.